we're now going to have a conversation between Cath and David, who are hopefully going to share their perspective of shared decision making.
Hello, everybody. This isn't just a kind of political correctness of having the learned experience voice in this kind of session, but because it makes sense, really, that we share this kind of experience. Now, the three of us all have very different, we come from a different direction in terms of our experience, but we're all kind of in that middle tier of that pyramid that Jonathan shows. In other words, we've all got long-term conditions. And what we're going to talk about in the next 10-15 minutes is to give some feedback about that and what we think the lessons are from that. I'll invite Cath to talk about her experience next, but first, before I do that, let's just say very briefly something about our friend Thatcher. Thatcher is a software developer living in the States, although she's had experience of the UK system. And we asked her because she's very articulate. She has primary diabetes, so she's had to live with it since she was diagnosed as a kid. And I suppose it's fair to say all three of us have high health literacy. So again, I took the point from Jonathan's presentation. There's a real challenge for adapting the thinking about this if the customers of the clinicians are in fact less advantaged than we are. Although I would stress that I think anybody with long-term conditions, by and large, if they've had to partly self-manage, they actually learn a lot about their condition anyway. So that's something to bear in mind with people with chronic conditions. It's a bit different if there's a citizen just turning up needing an op or something, then maybe they aren't. But we're on a particular group of people. So taking Thatcher's situation, I actually met her at a conference in Barcelona, of all places. But I was very impressed by her. She's very keen to help develop new software to support people with diabetes, type 1 diabetes. But what she told us in our interviews, that what's really important is you may, as a young person, before your late teenage years, have really quite good integrated care in the States. But once you're over a certain age, you're on your own virtually, and then it's just about the luck of the draw in terms of whether your job provides good health insurance or it doesn't. If you're out of work, you're in trouble. And even if you have good health insurance, it really depends on the clinician you come up against.
Being dual US-UK, I have a fairly, most of my adult life and my diagnosed life has been in the US. But what's been fun, I mean, fun's relative, right? But what's been fun is I have a friend who is a junior doctor in London. And so, and a good friend. And so when I was diagnosed, he's whatever I can do to help, I'm happy to. At that point, he'd just gone through, I believe it's DAFNE, it's DAFNE training, which is diabetes specific. And we just didn't have anything even close to that. One of the things with the US system, at least as far as diabetes is concerned, is there's an incredible amount of coordinated care when you're in the juvenile system. So your endocrinologist will speak with your dietitian, who also speaks with any mental health professionals that you go to. You have training both for you and for caregivers, parents. When you are in the adult system, everything is fractured. It's like, if you talk to a 16, 17, 18-year-old person who's being diagnosed, my advice always is stay in juvenile care for as long as you can. But
aren't you also reliant on whether or not the insurance is there to provide that? So, that can cause some disjointedness.
Oh yeah, no. I've been very lucky that I've worked at companies that have had very good insurance while I've had diabetes. And as far as David, to sort of address like patient advocacy or getting coordinated care as a person with a chronic disease, it is very difficult. And I have fired doctors, and I tell people when I speak, if I can impart one thing to any patients that are in the audience, doctors, that's great, but patients, is that you can fire your doctor, because people get white coat syndrome, as it's called, and whatever your doctor says must be correct. And that is not the case. And I've had doctors where we've had a good relationship because they just tell me nothing and just let me manage my condition in the best way possible for me. And I've been in situations where I'm like, I know the tech I want to run. I know how I'm running it. I don't want your input. Write my prescriptions for insulin and sensors and leave me alone. And it's been a good relationship because of that. I'm now in, I'm now in a relationship with my endocrinologist, who has a terrible bedside manner, but I'm fine with that because I appreciate the data and her insight and the fact that she is open to and supportive of community-built software and insulin delivery systems. So those things outweigh, I don't need my a handheld at this point. That's not what I'm looking for. I'd much rather have a doctor who's top of her field, is going to bring information to me that I don't know, than I am looking for someone to, ask, are you okay, for the 5th time?
You get that. You don't need that.
Yeah, and that's where I'm at. That's very different. And I think it's important to recognize that you're not going to, have an empathic, educated, patient first doctor that's going to be right for everyone. There's no mold of a physician that's going to be right for every patient. So it's very important as a patient to seek out the doctor that works with you. But I think it's also important to consider where a patient is being pulled into the process before you even get to the patient. So something that is important and very integrated in diabetes care is device design. So the device that I wear, for example, the pump that I have on right now, it's great. I love the interface. It's the best in the business. This is a third-party clip that I bought off of Amazon for, I think, about $5 that fits on it. That means it stays in my pocket.
Right.
And the case that they gave me that has a similar clip adds bulk to the pump itself. And being a woman, all my pants are terrible and have terribly small pockets.
Yes.
And so I don't want it. I don't want it to be bigger. And when I clip it, to my belt or to my pants, the way that the pump company designed it to, it gets knocked about and, thrown, whether it's around a corner or when I'm walking my dog and it gets knocked off and then it ends up on the ground. And if I'm lucky, it doesn't pull the pump side out and it just hurts. If I'm unlucky, it pulls the pump side out and then I have to do the whole reload. And, if I'm busy in an hour, that might be, in 10 minutes, depending on what else I have, going on. Did I walk the dog in a quick 10 minutes before I had another meeting? A nice jaunt during my lunch break, if I take a lunch break, where I have an extra, 15, 20 minutes. And that's if I'm very good and fast at changing a pump site versus someone who's more nervous or, just not feeling as comfortable going quickly, changing. So there's a lot to be considered in device and procedure, medication design.
That's the thing about user-led design, isn't it? Being involved, What I'd like to do next is actually ask Cath to introduce herself and talk about her experience, and then I'll talk about mine from a different angle.
Sure. So I'm in my 40s. I've had various health conditions for life, one of which is bipolar. So that's got me in contact with regular mental health professionals, as well as my general practitioner on a regular basis for medications and things like that. I've also had gynecological experiences, unfortunately, with various surgeons. But one of the things that I did want to talk about was for mental health. One of the problems, one of the anxieties of having a lifetime condition in the NHS, in this, my own experience was that every time I went to the GP, it would be a different GP. So it would be the same surgery, but I wouldn't be able to see the same GP. This was in London and Bristol, where I lived previously to now. And one of the anxieties as a patient, knowing that I have a lifetime condition, is that every time I go to the GP, I have to explain everything from day dot to a new person. In theory, there's records in front of them that they can read, but my experience was continually that they didn't read them before the appointment, and I felt anxious that I wasn't able to get over my point of view of whatever it was I was there for, be it medication altering, or maybe suggesting that I maybe need to go back into some kind of therapy if I was having a downturn. I was listened to as being the expert of my condition, but ultimately it was down to them. And I found a resistance when I resisted more medication, because I was told that this was the way it was done. Although I stuck to my guns and refused the extra medication and got through it with other therapies, it wasn't approved of by that particular GP, but was by the next one. So it was a case of disjointed care, really, because every GP was different, until I moved to somewhere with a smaller population, with a GP that has known my family for decades, who was actually able to stop, say, okay, where are you right now with your condition? What medications are you on? Do you like them? Can we change them? If you need to, just make an appointment. We'll have a look through and see which drugs are available at this time. It was a completely different experience, and one that I wish we all had when we went to the GP with mental health issues. Some were very good at holding their hands up and saying they really had very little experience of mental health and those drugs, and they would like to research further before treating me, which was nice to hear. So I had that experience with my mental health. I've had various surgeries for different things, but one incident, going back to what you were saying about Thatcher sacking, or having the choice at least to sack her practitioner, I had to have a gynecological procedure, and came up against a physician who didn't want to listen to what I wanted. I said that I couldn't take the medication. I gave him my reasons, and he ignored them. All he heard was, I don't want to take the medication, I want the surgery. And he kind of made me feel like I was doing the wrong thing, like a naughty schoolgirl, because he made the implication that I was putting my life deliberately in danger by having surgery when there was an easier option, which was medication. He refused to listen to the fact that I'd had a liver injury previously caused by medication, and that I was anxious about taking any more drugs, and that I had looked into this surgery, and I knew that it was probably the safest one and the least invasive as far as gynecological things go for women. He performed the surgery very badly, didn't get the outcome that we wanted, and in post-surgery, hours after waking up from very, very nasty anesthetic drugs that I asked them not to give me, again, my request was ignored, and he just did what he wanted to do. He told me that the reason the operation did not succeed was because my uterus was the wrong shape. Now, waking up post-operation and hearing that it's not a success is one thing, and then being told that it's your fault that it's not been successful was a double blow, and caused me to make an official complaint and to seek a second opinion. I did seek a second opinion, and it was actually his subordinate that actually came up with the idea of saying, well, actually, I've seen the camera footage from before you had the operation. This isn't true. I can do this operation. So I gave him a chance to do it, which he did successfully with half the drugs for anesthetic, so I wasn't as sick, and it was successful. And post-operative, he said, straightforward, no problem. He also explained to me afterwards how long it would last, what my outcome would be, maybe 3 years, 5 years, 10 years time afterwards, and when to report and what to report if I had any symptoms. I felt completely confident that I knew exactly what happened to my body while I was in surgery, and I knew what to expect afterwards. night and day from the surgeon before that. So I guess I could say it's a mixed bag from the NHS, really, patient-wise.
Cath, thanks. Now, we've included myself. I have to confess, I'm a retired clinician, so I should know something about health, but I'm also over the age of 70, so I'm typical of the group that GPs have to deal with now, which is I'm multi-morbid. In other words, I have at least 3 chronic conditions. In fact, one of them isn't age-related at all. I've had it since I was in my 20s. So I've had a lot of experience, more than, I hate to admit it, but nearly 50 years experience of the NHS dealing with that particular condition. And it's very interesting just picking up on the points that have been made already. I would certainly agree. I think I've been very lucky. Certainly my GP, when I first went to his practice, I had quite good experience with GP throughout my life, but this guy impressed me, and he's been my GP for many years now, is that when there was any issue about my gastric problem, we would sit down together and he would say, look, I don't know for sure about this. Let's look at the data. And I don't believe that's just because I was a doctor. You know, what he'd do is, and you could see it was a habit, he'd turn the computer screen so we could both see it, and we'd look at some of the latest information to see whether we could get a proper answer to whether or not there was a risk. We were looking at the questions of risk in terms of changing my meds and so on. So I thought that was really positive. It was just the whole thing was constructive. And I think there's no doubt at the surgery, people will ask for him, you know, because he's respected for that. They know they'll be treated well. Whereas I have had occasionally one of the less experienced GPs tell me, no, we can't change the medication you want because NICE says, the NICE guidelines say X, and we have to follow the NICE guidelines. I mean, the fact is, they don't seem to understand guidelines are guidelines. They're not the word of God, but that's the way things are. Certainly from what Cath was saying about her experience with clinicians in the hospital, I've had the same kind of negative experience where I went to see a gastroenterologist and my symptoms have been playing up. And I realized as soon as I walked in the door, she'd decided that the issue was that I was overweight. I mean, I'm a bit overweight. I mean, not major overweight, but she was saying, oh, it'll all be sorted out if you lose a few pounds. And I was saying, well, you know, I've had very stressful time in the last 6 months. I wonder if that's a factor. No, just lose weight, that's it. You know, and you just felt she'd got a closed mind, really. And she was so focused on a particular symptom, she wasn't interested in looking at me in a holistic way. So inevitably I said, okay, and I ignored her advice and just got on with it because she obviously wasn't going to help. But that's okay. I mean, I had got good backup from my GP and so on. It wasn't a problem. Just to finish off as a positive example, just recently, again, this is kind of an older person's thing. I had some problem with my tongue, and I had to have a biopsy. I went to see the maxillofacial surgeon, and again, I got a really positive response from her in terms of discuss just the things that Jonathan was talking about in terms of talking about the options of no treatment, and also just the question of talking over, saying, look, it's your decision. You know, you could possibly live with this for a certain period of time. Here's what the risks. You could have an operation, but of course that's also got risks involved. What do you think? And I have to say, I ended up congratulating her on her good practice. And she was deeply embarrassed. She didn't expect the patient to turn around and tell her she's doing a good job, but certainly she was. Look, I think that's probably enough for now. And I'll hand it back to Jim, if that's all right.
Yeah, thank you, David and Cath. And a lot of questions immediately come up in my mind. To what extent your different experiences and where you've been spoken to involved are also around perceptions around gender and understanding and professionalism and all the rest of it. And so it raises all sorts of questions around inbuilt biases that are in conversations quite often, and inbuilt inequalities which are often there in conversations as well, around some subjects which are very topical at the moment around race, but also around gender and people's perception of the person sat opposite them. And I think this is why it's so important. And I think your example, Cath, really highlighted the two very different conversations. One where, we're the expert, we know what's best for you, and sorry, but you're just a person with the illness. Well, what do you know? As opposed to someone who really listens to you, listen to why that decision was important to you and your reasons behind it, and then understood that course of action and could support you with it. So thank you for articulating, those, very different experiences in highlighting the importance of the skills which support all of this.